This is our second Yuva CME, and our speakers are Sukarna, Nidhorini, and Vasudha in this order. So I will request Sukarna first to present his presentation. Over to Sukarna.
Thank you, sir. Good evening to all respected teachers. I am Dr. Sukarna De, second year PGT of Malda Medical College, Department of Pediatrics. Today I am here to present the recent updates in tuberculosis. So tuberculosis is an important cause of mortality and morbidity among our children worldwide as well as in India. India has the highest burden of both tuberculosis and MDR tuberculosis. And what are the recent changes here? We are here to discuss. RNTCP, the revised National TB Control Program, was renamed as National Tuberculosis Elimination Program in 2020. The national strategy for ending TB is universal dark sensitivity testing by culture and or molecular methods for all tuberculosis cases. So there are huge burden in our country due to this particular disease. The incidence is about 199 per 1 lakh of population, and the estimated MDR or rifampicin resistant cases are about 9.6 people per 1 lakh of population. There are mainly 4 pillars for our elimination target. What are they? They are called as DTPB, like detection, treat it, prevent it, and beat the tuberculosis. There are 2 cases which I got in here in Malda Medical College. And first case was a child Piyush Mandal, 3 years 4 months old boy from Malda, presented in our OPD with a low-grade fever. We admitted the patient. There is a history of low-grade fever since last 15 to 20 days. Then it became high rise since the last 3 days. There are 3 episodes of non-bilious vomiting without blood mixture, and there is of course a family history of tuberculosis. The child's father was taking drugs for tuberculosis. We investigated the child. Chest X-ray revealed bilateral multiple patchy opacities and bilateral mild pleural effusion. The TST test or the tuberculin sensitivity test was positive. We got gastric lavage sample for CBNAT, but AB was non-detected. As we are giving antibiotics by IV route, but documented fever did not subside, so we started ATD on high index of clinical suspicion, and the child was labeled as clinically diagnosed pulmonary tuberculosis. Here is the second case. Anisha Khatun, 1 year 6 month old girl from Malda, admitted in our ward for fever for 1 month, especially at night. And there is profuse sweating at night and gradual weight loss for the last 20 days, documented, with frequent vomiting for the last 7 days and multiple episodes of convulsion in the last 24 hours of admission. Child presented with unconscious state and decorticate posturing. We first done the routine test, CBC, CRP panel for the fever cases, but we done the lumbar puncture and the CSF report was 120 cells, also all were lymphocytes. Protein was 228 milligram per deciliter and sugar was 30. PST reveals a negative report, but MRI was suggestive of hydrocephalus, dilated lateral ventricles with thalamic infarct. So we marked the patient as TB meningitis and ATD drugs was started. ATD was started. So tuberculosis as a huge burden in our country, so we have to properly address its properly detect the patient in time and do the relevant investigation and properly send the patient to proper places to get the full course of treatment and the care. And there are some recent diagnostic advances in tuberculosis. What are they? As a diagnostic context, the laboratory plays a decisive role in identification and drug sensitivity testing for tuberculosis. The diagnosis is made via LED microscope, PCR-based technique, and the active TB and the latent infection, which are more common in these days, are detected by some immunological assays. The identification of the microbacteria, the positive organism, was based on PCR-based methods and hybridization assays. There is also a fast DST like liquid culture and the line probe assays. Here are the some tests which are improving day by day by their cost effectiveness, less time consuming. First, we have in previous days we used to done the light microscopy with a sputum sample, and its detection rate was 60 to 70%. But there was some fluorescence microscopy with high detection rate, less time, but the disadvantage was high cost. Then LED microscope came, it cost low. Then there are alternative culture-based methods. Solid media, of course, Lowenstein Jensen and stone bricks media, which are gold standard, but it took lots of time, like 2 to 4 weeks. Then liquid media came, 20% more sensitivity than the solid media, and it took 10 to 14 days for the detection. But the major disadvantage is, as it is liquid media, so contamination rate is very high. And there are some other culture methods like Middlebrook 7H9 broth supplemented with 10% OADC and Panta to prevent the other organism to grow. Some commercially available kits are there like MGIT, Safety Check, Backtech, 9000 MB, etc. There are some DNA-based tools. What are they? Some classics, NAT, nucleic acid amplification test is detected from extrapulmonary specimen, and it took around 3 to 6 hours for the result. And PCR assay, it is a PCR assay using the oligonucleotide primers to amplify the DNA fragment. And the examples are AMTD test and Roque Amplicod MTB test. Then came the loop-mediated isothermal amplification. Here, the target DNA under isothermal, like 65 degrees centigrade, the DNA are amplified and DNA are detected by visual method directly from the specimen, and it took very less time, like within 2 hours. And there comes the expert MTB or RIF nucleic acid amplification test. Here, the main advantage is that the sputum processing, DNA extraction, amplification, all are done in one single step. It took around 2 hours, and it detects the rifampicin resistant as well as the bacteria. The sensitivity is around 95% and specificity 98%. There is no risk of contamination and no need for the biosafety facilities. Here are some latent TB or species identification technique like IGRA, interferon gamma release assay, but this is not used in India. It measures interferon gamma following stimulation by the TB specific antigens, but it usually could not distinguish between the latent and the active TB. There are some DNA technologies like PCR and restriction enzyme analysis of the gene coding of the heat shock protein, and the examples are AcuProbe, Genotype, MTB, etc. And some immunochromatography method like Tona capillary TB and BD's MGIT tuberculosis ID. Now comes the drug sensitivity testing or DST. Some non-commercial culture-based methods gives our result within 1 to 2 weeks of inoculation, and the methods are different methods like MODS, TLA, CRI, microscopic observation of drug susceptibility, thin layer agar, and colorimetric redox indicator. And some commercially available are Bactec alert, MG system, etc. There are some rapid molecular based which gives result around 24 to 48 hours via hybridization assay, and the examples are these genotype MTBDR plus. Here comes the recent treatment. Recent treatment regimen are changed from category. Previously, it was category 1 and 2, but now there is only drug sensitivity tuberculosis and multi-drug resistant or rifampicin resistant tuberculosis. Category 1 or tuberculosis, rifampicin sensitive tuberculosis is same as before, but there are some changes in the MDR TB or rifampicin resistant TB. The intensive phase is around 4 to 6 months. Initially, it's 4 months, but it can be extended up to 6 months. Here are the DAG, bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, isoniazid, and ethionamide. But we have to give bedaquiline for the 6 months. So if we continue intensive phase for 4 months, then we have to extend bedaquiline for another 2 months. And with that, we have to start the continuation phase, which is in total 5 months. And the drugs are levofloxacin, clofazimine, pyrazinamide, and ethambutol. So if we start and end of the 4 months, we have to give the intensive phases drugs. And if intensive phase is not extended, we have to give bedaquiline with the continuation phase drug for the up to the 5th month. And then after that, from the start of 7th month and the end of 9th month, we have to continue the continuation phase. The changes are key. We don't have to extend intensive phase based on the smear positivity or not. Here a few lines for latent TB infection. What is it? It is a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigen with no evidence of clinically manifest active tuberculosis. And isoniazid and rifampicin for 3 months are given. We can take some measures to prevent it. How to prevent? To stop the transfusion via the airborne infection control. In COVID situation, lots of common people have learned how to use the normal surgical masks and the N95 mask. By using this, we can prevent this airborne infection and tuberculosis. And we have to thoroughly contact tracing and the reverse contact tracing via the patient we admitted in our ward. So by thorough searching, we have to we can prevent the further spread of tuberculosis in our community. There are some take-home message which I want to give. Tuberculosis is a huge burden in our country, both by economical and by health, by the health facilities. So we have to detect it early, complete the full course of treatment with diet, drug, and empathy, properly address the multi-drug resistant tuberculosis, and of course, treat the patient, not the report he is carrying. Thank you.
Whether the second child is BCG vaccination is given or not.
Can you please repeat?
Second child meningeal inflammation is there. And the second child or BCG vaccination or not?
Sir, if there is an active infection, we usually told the mother to withhold the BCG vaccination.
Chaduda, let's move on to the second speaker.
Second speaker. Let's continue to second speaker.
Nidhorini.
হ্যাঁ স্যার স্যার স্টার্ট করছি
Start karo.
evening. Respected teachers, I am Dr. Nirjoyini Ghosh. I am senior resident in Arjikar Medical College. I will be talking about AUFI, acute undifferentiated febrile illness in pediatric population. What is AUFI? AUFI is defined as temperature of more than 38 degrees centigrade for duration 2 to 14 days without any signs and symptoms localizing any organ or system. One of the commonest cause of visiting healthcare center in India. Severity of AUFI may range from mild or self-limiting illness to life-threatening conditions. From PUO or FUO, that is fever of unknown origin, because in FUO, fever should be present at least 3 weeks without identifiable cause, even after investigation. So, AUFI is absence of localizing sign of the cause of febrile illness. Absence of localizing sign causes diagnostic challenge in patient less than 36 months and increased risk of occult bacteremia and serious bacterial infection in less than 3 months of age. According to different etiology and variable risk of serious bacterial infection, AUFI in pediatric age group can be subclassified into neonatal AUFI up to 1 month, 1 to 3 months, 3 months to 36 months, and more than 36 months. In neonatal AUFI, in neonate, there is very limited number of signs of infection, and that too are non-specific. They are highly susceptible to serious bacterial infection due to immaturity of immune system, vaccine naivety, exposure to unique pathogen in perinatal period. After control of ambient environmental temperature and adequate hydration with increased frequency of breastfeeding, if the baby is still febrile, possibility of serious bacterial infection should be entertained even in an apparently healthy neonate and should undergo a sepsis screen. CBC, CRP, urine REME, blood culture, urine culture, chest X-ray, peripheral smear for malarial parasite should be done. After obtaining relevant investigation, empirical antibiotic therapy should be initiated at the earliest. Antibiotic therapy depends on common causative organism which is different in different geographical location and sensitivity towards antibiotics of that geographical location. Overall, empiric antibiotic therapy include ampicillin plus gentamicin or ampicillin monotherapy or cefotaxime monotherapy. AUFI in 1 month to 3 months. In 1 month to 3 months, generally self-limiting seasonal viral illnesses are the most common cause. However, possibility of serious bacterial infection should always be entertained and all be subjected to sepsis screen and empirical antibiotics similar to neonates. In well-appearing infant of this group under watchful observation, antibiotic can be deferred, but sepsis screen should be sent. AUFI in 3 months to 36 months. Mostly due to viral infection. Goal to identify serious bacterial infection, identify red flag signs, which are temperature more than 40 degrees centigrade, WBC count more than 25,000, raised TSS, CRP. If high risk, blood culture should be sent and empirical antibiotics like ceftriaxone IV 100 mg per kg per day in 2 divided doses should be started. AUFI in 3-year and older children. A plethora of microbes, bacterial, viral, rickettsial, protozoal organisms are responsible along with overlapping etiologies. Non-specific or overlapping clinical symptoms along with the scarcity of available appropriate diagnostic facility often result in an indiscriminate or irrational use of antibiotic and anti-malarial. Common causes of AUFI in India include malaria, dengue, influenza, scrub typhus, leptospirosis, enteric fever, etc. The frequency of AUFI is also associated with seasonal variation, like malaria, dengue, scrub typhus, leptospira peak during the rainy season. Chikungunya, enteric fever peaks during post-monsoon period. Acute is categorized under acute is presents with acute localizing infection either or acute undifferentiated febrile illness. Acute localizing infections present either with respiratory symptom or GI symptom or urinary tract symptom. Acute undifferentiated febrile illness can be classified malaria and non-malarial, as malaria is can be a leading cause of acute undifferentiated febrile illness. So we should identify that first. In non-malarial AUFI, classified into viral, bacterial, and parasitic. Viral infections, arboviral infections like dengue, chikungunya, or influenza, but most of the time influenza usually present with respiratory symptom. Bacterial infection, bacteremia can be due to enteric fever or other bacteria like E. coli, Staph aureus. Zoonotic infection can be there like spirochetal infection, leptospira, relapsing fever, rickettsial infection, scrub typhus, spotted fever, murine typhus, etc. Parasitic infection can be hepatic amoebiasis, acute schistosomiasis, acute trypanosomiasis. Diagnosis. First, we should consider clinical scenario and epidemiological information. Then we should conduct disease-specific diagnostic test. We should rule out malaria first by rapid diagnostic test that confirms parasite antigen like histidine-rich protein 2 and Plasmodium lactate dehydrogenase in blood with 95% sensitivity and specificity for Plasmodium falciparum. Thick and thin smear for malarial parasite should be done. Rapid diagnostic test. If malaria parasite is negative, then malaria RDT is negative, then we should think for other AUFI like RDT for dengue specific IgM test and or NS1 antigen. Enteric fever is diagnosed by Vidal test or Typhi.IgM test. ELISA for IgM, scrub typhus is diagnosis by ELISA for IgM antibody or OL-Felix reaction. OL-Felix reaction, OXK is positive, OX2 and OX19 is negative. It is cost effective, easy to perform, and availability of the result in overnight. Leptospira is diagnosed by IgM ELISA test or microscopic agglutination test. Disease-specific treatment of common diseases causing AUFI. Malaria. Uncomplicated Plasmodium vivax malaria is treated with chloroquine 10 mg base per kg stat orally, followed by 5 mg per kg at 6 hour, 24 hour, 48 hours. Total 25 mg per kg and primaquine 0.25 mg per kg OD for 14 days to prevent relapse. Uncomplicated Plasmodium falciparum malaria is treated with artesunate 4 mg per kg per day orally into 3 days and single dose of sulfadoxine pyrimethamine. Sulfadoxine 25 mg per kg and pyrimethamine 1.25 mg per kg, or formulated tablet containing 20 mg artemether and 120 mg lumefantrine can be used as a 6-dose regimen orally twice daily for 3 days. Single dose of primaquine 0.75 mg per kg for gametocidal action on second day. Complicated malaria patient can be presented very sick. Patient should be stabilized first. Airway, breathing, circulation should be stabilized. In severe malaria anemia cases, blood transfusion may be needed. Patient should be treated with IV quinine. Next, we come to dengue. Patient with dengue fever can present as mild dengue, moderate dengue, or severe dengue. In case of mild dengue, undifferentiated fever without any complication, home management can be done with plenty of oral fluid and paracetamol. Moderate dengue fever with comorbidity and warning symptom should be hospitalized, and we should monitor vitals, blood pressure, platelet, hematocrit, and urine output, and we should give IV fluid as per hematocrit and sickness of the patient. Severe dengue fever with hemorrhagic shock, hemorrhage or shock, multiple organ involvement. We should admit the patient in intensive care. Treatment of shock should be done with normal saline bolus. Blood transfusion may be needed in case of severe bleeding. We should watch for signs of fluid overload. If detected, then furosemide and oxygen should be given. Scrub typhus, doxycycline 4 mg per kg per day per orally or IV for 7 days or 3 days after fever subside. Tetracycline, chloramphenicol, azithromycin and rifampicin can be used. Next we come to enteric fever. Uncomplicated typhoid fever is treated with third generation oral cephalosporin, cefixime 20 mg per kg per day for 14 days. Typhoid fever is treated with IV ceftriaxone or cefotaxime 100 mg per kg per day for 14 days. Next, we come to leptospirosis, usually responds with oral amoxicillin or azithromycin or cefixime or doxycycline. For very severe cases, parenteral penicillin 50,000 to 1 lakh urine per kg per day. We come to some cases. Case number 1, 5-year-old boy came to emergency department with high-grade fever for 4 days with headache, malaise, anorexia and pain abdomen for last 3 days. On examination, hepatosplenomegaly is present and mild dehydration present. We admit the patient because of high-grade fever and inability to take adequate oral feeding and dehydration. Then we send routine investigation, CBC, CRP, LFT, sodium potassium, urea creatinine, MP, MPDA, blood culture, urine, REME and culture. IV fluid for dehydration and antibiotic for high fever. Antibiotic, ceftriaxone, and for high fever, paracetamol started. Fever not controlled by next 24 hours. High-grade fever without decrease in frequency. Child looks sick. Appearance of maculopapular rash in lower lip. CBC report came. It showed leukopenia, thrombocytopenia. LFT show hyperalbuminemia, elevated hepatic transaminases. Also, there was hyponatremia and elevated CRP. Blood culture report averted. Urine report were normal. MP, MPDA both negative. Blood then sent for Vidal test, IgM dengue and IgM scrub typhus. Oral doxycycline started at 4 mg per kg OD dose as we are thinking of scrub typhus. Within 12 hours, fever reduced in frequency. Subsequently, Vidal dengue IgM, Vidal came negative, dengue IgM came negative, but IgM for scrub typhus came positive. Although there were no eschars, but still scrub typhus should be, possibility of scrub typhus should be kept in mind. Case number 2. 8-year-old boy presented with high-grade fever for 5 days, yellowish discoloration of eyes, urine, nausea and vomiting. He has history of fever, malaise, anorexia 2 weeks back, which was subsided after getting treatment from local practitioner. On examination, hepatomegaly was present, urine output was low. Routine blood report and blood for HbSAg, anti-HCV or HAV and routine urine were sent. We are thinking of viral hepatitis. Patient was admitted due to high fever and started on IV fluid, paracetamol, on vitamin supplementation, stool softener given. Report came subsequently, showed direct hyperbilirubinemia, hemoglobinuria, albuminuria with high CRP. HbSAg, anti-HCV, anti-HAV is not reactive. Sodium, potassium, urea creatinine was within normal limit. Fever not decreased, BP monitoring done regularly, which was normal. We sent blood for cholesterol, C3, C4 level, Vidal, dengue, IgM, scrub typhus, and IgM all came negative, but fever and jaundice were still persisting. We again re-examined the patient, took history meticulously, found we have missed one history. His father is a farmer and the boy goes to the field with his father every day. We thought about Wells syndrome and sent blood for IgM leptospira, started azithromycin 10 mg per kg per day. Patient starts to improve subsequently. Blood report of IgM leptospira came positive. Thank you.
How is AUFI is different from fever without focus?
AUFI is fever without focus, but it should be within 2 to 14 days. If and mostly infective in origin. It is different from pyrexia of unknown origin. That is more than 3 weeks duration.
No, it is not pyrexia of unknown origin. Fever without focus. And how do you know it is of infectious origin?
No, AUFI is fever without focus is AUFI.
How is it different from fever without focus, or is it almost the same?
Almost same.
Apurboda, would you like to add something? Chaduda, any question?
না ঠিক আছে ডক্টর ঘোষ কি বলছেন অপূর্ব ঘোষ ডক্টর ব্যানার্জি সুস্মিতা ব্যানার্জি কিছু বলবেন
I think the question বোধহয় যেটা অভিজিৎদা জিজ্ঞেস করছিলেন that there might be non-infective causes also of fever where there is no focus. That is something you haven't mentioned. So at what point would you start thinking that, okay, this is not an infection, there might be another cause for fever that is non-infectious, and what would be your differential diagnosis then if you could not detect the infection?
So if CRP became negative, or in CBC neutrophilic count is not high, and blood culture or urine culture became negative, then we think of cause of fever other than infection, like collagen vascular disease, or any cases of leukemia, or etc.
Okay, so that's your differential diagnosis. Good. HLH is another one,
Yes,
and
yes.
several others. But many of these also have a high CRP, high neutrophilic leukocytosis, isn't it? So
Yes.
we have to always consider that when we are sort of running out of infectious etiologies to detect, when all our tests are failing to detect anything infectious, we always look for, in our country especially, we always look for infections
Tuberculosis.
first.
Yeah.
Yes. But when all the infectious tests are coming back negative, then we have to start thinking of these other non-infectious causes, as you have rightly mentioned.
MIC can be.
True. COVID, yeah, MISC in this season, definitely. Correct. I think one more thing I would say, if you don't mind, Boshuda, is that you're learning to present. No, so this exercise is in a way of practicing and learning how to present effectively. I think don't write your slides in the form of text. Write your slides in the form of points, and then talk from those points. So don't read out. Does that make sense?
Yes, yes, yes.
Okay, so that is something to practice on for next time. Okay.
Thank you. Okay, thank you.
Okay.
one thing during delivering your speech, you are always rolling your body to and fro, and this should be corrected.
Yes, sir.
When I give you lecture in the auditorium, then it is looking very
Okay, sir.
But very comprehensive. Thank you.
Okay.
We can go on.
Yeah, yeah.
yes.
Thank you, Nidharini. Now we should move to the next speaker, Dr. Boshuda Roy, for our presentation. Over to Boshuda.
Good evening, everyone. I'm Dr. Boshudha Roy. I'm a bonded SR at Bardhavan. My topic of presentation is for today is Plasmodium, the re-emerging protozoa. My first case is a 6-year male child weighing
লাইটটা অফ
22
হয়ে গেল
kg.
কেন বসুধা? আমাদের টেস্ট রান করে দিলাম, স্লাইডটা তো স্ক্রিনে কিছু দেখা যাচ্ছে না। কিভাবে টেস্ট রানটা করালাম?
Sir, এখন দেখা যাচ্ছে?
এখন তো স্লাইড স্লটারে দেখা যাচ্ছে।
Okay, sir.
স্লাইড শোতেও তোমার দেখা যাচ্ছে না। না,
ঠিক আছে, ওকে,
এরম করেই করো, doesn't matter.
স্টার্ট, ডাজন্ট ম্যাটার।
6-year male child weighing 22 kgs was referred to BMCH from Gushkora BPHC with history of intermittent high-grade fever, dysuria, abdominal pain, and confusion for 3 days. He had anorexia, malaise, and myalgia. On examination, he was drowsy. Temperature was 102 Fahrenheit. Patient had mild icterus and conjunctival suffusion was present. There was no neck stiffness. His pulse was around 100 beats per minute and blood pressure was 96/54 millimeters of mercury. On auscultation, chest had bilateral basal crepitations. Abdomen had 2 centimeters of hepatomegaly. However, the spleen was not palpable. During the ward stay, the patient developed rigors with drenching sweats and high-grade fever. He had rapid breathing and there was occasional drop of saturation. So initially on taking the history with the clinical examination, we thought along the line that probably this was a case of sepsis, most probably meningitis, or the patient may have dyselectrolemia or may be suffering from hepatitis. The following investigations were sent: complete blood count, urine for routine examination along with culture, CSF analysis was sent, thick and thin smear for malaria, hepatitis A antigen, hepatitis B, typhoid, dengue NS1, LFT, blood for culture and sensitivity. On getting the preliminary reports of the complete blood count, the hemoglobin was 12.7 gram per DL. Total count was 17,700, out of which neutrophils were 82%, lymphocytes were 13%. Platelet was 1.5 lakhs. Urine had 5 to 6 pus cells. LFT showed the total serum bilirubin to be 4 milligram per deciliter with direct bilirubin to be 1.2 milligram per DL. The hepatic enzymes were raised above normal.
Can you go on to the next slide, because we are still on slide 1, so you need to click on the next slide.
Okay, ma'am.
Can you go to slide? Yeah, so every time you change, go to the next slide, okay? Otherwise it's not showing. Go ahead.
Okay, ma'am. Chest X-ray showed bilateral pulmonary infiltrations like ARDS. Patient was negative for hepatitis A and hepatitis B. However, on random blood sugar examination, patient had persistent low CpG below 50 milligram per DL. The thick and thin smears blood films for malaria showed positive Plasmodium falciparum in its ring stages. We also did a CT brain since the patient was getting consistently drowsy, which showed diffuse cerebral edema. Upon admission, the patient had 2 episodes of fever reaching up to 39 degrees Celsius, for which he was treated with IV paracetamol. He also had 1 episode of seizure, which was managed with IV lorazepam. However, progressively, the GCS of the patient dropped during the stay, and so he also had further more episodes of seizure, for which he was shifted to the ICU and had to be ventilated. Since we already got a diagnosis of malaria, and the patient was unable to take oral medication, we started the patient with intravenous artesunate at a loading dose of 2.5 milligram per kg at 0, 12, and 24 hours, followed by 2.4 milligram per kg once daily for 10 days, since the patient was still ventilated and in a drowsy state. After that, we started, since there was mild improvement of GCS, we put a feeding tube in the patient and we started on oral artemether and lumefantrine tablet combination. The patient was treated in the ICU for total 19 days. During the course of stay, he developed ventilator-associated pneumonia, for which we had to put the patient on IV meropenem. However, there was one discrepancy. Even after giving IV meropenem for 14 days, we saw that there was intermittent high-grade bouts of fever in the patient. So, since we decided to repeat the Plasmodium falciparum test, and the slides still showed positivity for Plasmodium falciparum. We thought probably this was a strain of resistant Plasmodium falciparum infection, and we changed the antimalarials to quinine and also added doxycycline on day 14. By day 16, the fever of the patient ceased. The patient was discharged after 23 days of stay with no sequelae. So the final diagnosis that we came for the patient was cerebral malaria, most probably due to a resistant strain of Plasmodium falciparum, complicated by hypoglycemia and ventilator-associated pneumonia. We take a quick look at the malaria transmission cycle. Here, the sporozoites we know that malaria is caused by the bite of a female Anopheles mosquito. The sporozoites are injected into the human host, and it enters into the liver, where the exoerythrocytic phase takes place. The sporozoites infect the liver cells, which develop into schizons, which release merozoites into the blood. The dormant liver stages of hypnozoites are found in Plasmodium vivax and Plasmodium ovale. The merozoites that are released into the blood further infect the erythrocytes to form further more schizons. Some of these merozoites also differentiate into the male and female gametocytes, which are then picked up by the mosquito, which bites the human host again. These parasites undergo sexual reproduction in the mosquito, and then they mature and are stored in the salivary gland of the patient, which further infects another human being when the same mosquito bites another human. And this vicious cycle goes on. Now we look at the various antimalarial drugs and the various stages of the cycle of the Plasmodium on which it acts. The tissue schizonticides are primaquine, pyrimethamine, proguanil, and tetracycline. The blood schizonticides are chloroquine, mefloquine, quinine, tetracycline, halofanthrin, sulfadoxine, pyrimethamine. The gametocytes are primaquine, the sporozonticides are primaquine, pyrimethamine, and proguanil. The clinical course of malaria on the bite of a female mosquito are the following. Either it can cause asymptomatic parasitemia, which is usually suppressed by the clinical immunity of a patient. It can cause acute uncomplicated malaria or severe malaria in a patient. The treatment of malaria caused by Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae are as follows. Chloroquine, which the tablet that we get is of 250 milligrams, which is 150 milligram base. Now it is given in three doses, day 1, day 2, and day 3 of 10, and followed by 5 milligram base on day 1. Then on day 2, 5 milligram base, and day 3, 5 milligram base. Also, the patient, if he does not have day 6 PD deficiency, is started on primaquine, 7.5 milligram base dose given of the tablet, which is given in a dose of 0.25 milligram base once daily for 2 weeks. Usually in India, the treatment of uncomplicated Plasmodium falciparum malaria, we have fixed dose combination tablets of artemether and lumefantrine containing 20 milligrams of artemether and 120 milligrams of lumefantrine. They are given in 0, 8, 24, 36, 48, and 60 hours. The weight and the age of the child are taken into account. The dose combinations are seen in the slide below. What is the definition of drug resistant? The World Health Organization has defined drug resistance in malaria as the ability of the parasite strain to survive or multiply despite the administration and absorption of a drug given in doses equal to or higher than the usually recommended dose, but within the limits of tolerance of the subject. Based on in vivo tests, the levels of resistance were defined as R1 and as when no asexual parasite and which do not reappear by day 28. Resistance stage 1 was asexual parasites disappear for 2 consecutive days but are present on day 7 or reoccur within 28 days in the absence of reinfection. Resistance stage 2 was asexual parasitemia does not clear but is usually 25% less than the pre-treatment level, where the first test was done on the admission of the patient. Resistance level 3 is asexual parasites persist above 25% of the pre-treatment level even after 48 hours of therapy. This definition was further modified by Bruce Schwartz to include that the amount of drug is active against a given parasite must be able to gain access to the parasite or the infected erythrocyte for the length of the time necessary for its natural reaction. Drug resistance leads to a delay or failure of the clearance of the asexual parasites from the peripheral blood, which can be seen on doing a smear test. What is multi-drug resistant malaria? This is a new term emerging where a person shows resistance to 3 different classes of anti-malarial drugs, 2 of which belong to 4-aminoquinoline and diaminopyridine classes. Nowadays, since clinical and parasitological diagnosis is of most importance, we further assess the treatment of malaria as early treatment failure, late clinical failure, early parasitological, late parasitological failure, and early response. What is early treatment failure? That the patient develops danger signs of severe malaria on day 1, day 2, or day 3 in the presence of parasitemia. Parasitemia on day 2 is higher than day 0, irrespective of the temperature. Parasitemia on day 3, along with axillary temperature more than 37.5 degrees Celsius, and parasitemia on day 3 is more than 25% as on the count on day 2. What is late clinical failure? If the patient develops the signs of severe malaria after day 3 or parasitemia and axillary temperature are more than 37.5 degrees centigrade from day 4 to day 28 and none of the criteria of early treatment failure are matched. What is late parasitological failure? If the patient develops signs of has parasitemia present in the blood, which can be identified by slide test, irrespective of the temperature or the clinical condition of the patient, it is known as late parasitological failure. Adequate clinical response is absence of parasitemia on day 28, irrespective of the axillary temperature and not meeting any of the clinical criteria for early or late clinical failure. Malaria is a dangerous infection that affects about 6 the death rates. In Eastern Mediterranean region being 3%. Most of these deaths are due to Plasmodium falciparum. However, Plasmodium vivax is now emerging as a cause of severe malaria. Now, till date, resistance has been identified for among the 5 species of malaria for Plasmodium falciparum, vivax, and Plasmodium malariae. Here we see a picture of the world map showing the resistance to various drugs, chloroquine, sulfadoxine, pyrimethamine, and mefloquine in different regions of the world. The various mechanisms of drug resistance. Chloroquine resistance is caused due to the increased capacity of the parasite to expel chloroquine at a rate that does not allow chloroquine to reach levels for inhibition of the hemopolymerization. The chloroquine efflux is at a rate of 40 to 50 times faster than the resistant parasite. It is also caused by mutations of the Plasmodium falciparum multi-drug resistant gene 1 and 2 and also Plasmodium falciparum chloroquine resistant transporter gene. Resistance to sulfadoxine pyrimethamine is due to resistance to dihydrofolate reductase and dihydroxyapatite synthetase enzymes, which are 800 folds less readily resistant than the strains in the sensitive ones. Quinine resistance is also due to Plasmodium falciparum multiple drug resistant strain 1. Mefloquine resistance is also due to polymorphism of the Plasmodium falciparum multi-drug resistant gene 1. The various hypotheses for drug resistance in India are taken as use of a single drug therapy instead of a combination, along with use of the drug for a lesser duration of time, bite by a mosquito carrying the resistant strain of Plasmodium, also genetic mutations of Plasmodium inside the mosquito. How do we tackle drug resistance? Research of new compounds with novel mechanisms have been carried out by WHO. The recent drug of dafenoquine is being used, which is trying to replace primaquine. Also, we are trying to reverse the resistance of two existing drugs by using genetic engineering. Now, the most preferred method used in India is genetic combination therapy of artemisinin along with lumefantrine. Monotherapy is usually avoided. Malarial vaccines, RTS-SA1 is usually used in the sub-Saharan regions to tackle drug resistance, which is very prevalent in African countries. Also, we have to stop the use of prophylactic anti-malarial use. Now I move to my second case. An 8-year boy residing in the slums visited the OPD on 15th of April with complaints of high-grade fever at Tilson Riger for last 2 days. The attending doctor suspected malaria because the patient belonged to a slum region and prescribed the rapid diagnostic test for malaria, which showed Plasmodium vivax malaria. Patient was treated with chloroquine tablet in divided doses as per the schedule along with tablet primaquine. The patient returned to the OPD on 12th of May again with the same complaints of high-grade fever with chills and rigor. The attending doctor suspected malaria again and prescribed, since the patient said that he had already been treated with malaria recently, that this time the doctor prescribed thick and thin smears which showed Plasmodium vivax again. Now we were on a vex as to what the patient was suffering. Was it a relapse, a reinfection, or a recrudescence? Now, reinfection had to be kept in mind, since keeping in mind the residing environmental conditions of the patient, he had chances of reinfection. However, relapse was less of a chance since the patient confirmed he had completed the complete course of therapy with primaquine, which decreases the chances of the persistence of the hypnozoites in the liver, which could cause relapse of Plasmodium vivax malaria. However, recrudescence could not be confirmed since there was no evidence of the thick and thin smear to be done on the first time the patient was affected with malaria. However, this time we decided to put the patient on artemether and lumefantrine combination. Thus, relapse and recrudescence can be better differentiated if we had the means to study the chloroquine blood levels in a patient to show the effectiveness of the therapy. Chemoprophylaxis is given in children who are traveling to places which have the high prevalence of malaria. The usual drugs used in India are doxycycline and clindamycin. Doxycycline above 8 years, 2 mg per kg daily, and clindamycin below 8 years, 10 mg per kg, BD dose for 7 days. Mefloquine, weight-based therapy, can also be used. Atovaquinone and proguanil are usually unavailable in India. Thank you.
Sushmita, any question?
Can I ask where your first patient, the child who was resistant to your initial course of antimalarials, where did the child come from?
Ma'am, the patient was referred to us from a BPHC.
From where? Which area?
Ma'am, Gushkara in Bardhaman.
Okay, and were you seeing more cases of resistance from that region?
No, ma'am.
No.
This was probably the first, but only case actually, and
Right.
that too, ma'am. The slide test actually, though I have mentioned here that we had done, we didn't do the slide on the initial day. We actually did the slide test on the second, when we saw that in even after giving meropenem, which is like high dose antibiotic, still the patient was having fever, and we had already changed the anti-malarials. Still, we decided to get a slide test done, and then we came to the provisional diagnosis. Probably it was a resistant strain, though we are still not sure.
Okay. Just to ask all the clinicians here, have you been seeing sort of more aggressive forms of Plasmodium vivax in the last couple of years? You know, when you have a complicated malaria, we usually suspect Plasmodium falciparum. But in our hospital, in the last year's experience was that we were seeing vivax presented as very complicated forms of illness. Anybody else with the same experience? What about you, Boshudha, in your institute?
Ma'am, actually, severe malaria, most of them, we have plenty of malaria cases, but severe malaria, usually we have very few patients, and most of them even they are undiagnosed, or even if they come in very bad condition, the patient expires before we can come to a diagnosis.
Okay.
Chaduda, Dr. Shike Ghosh, do you have any question?
I asked whether any member of the family or they have affected of this resistant type of malaria, have any history of that, by the locality of that from the Guskara of the patient, suffering of resistant type of malaria.
No, sir. At that moment, the other members of the family were not suffering from malaria.
Okay.
Which test you give more importance, the antigen test or the slide test?
Sir, slide test is always better since it is more sensitive, and we can identify the type of the Plasmodium effective, and also if we can do the parasite count.
Slide test is more important.
The antigen test always indicates active infection, or it may also indicate past infection also.
Sir, it can be positive up to, I think, up to 1 month also. Sometimes we can get positive tests.
Direct slide test is
False
more
positive tests are also, sir, there. False positive test is also there for rapid diagnostic tests. False positive numbers are also higher.
Yes, after an infection, the antigen is still there, and the MPDA test actually picks up the antigen. So naturally, it does not either indicates an active infection, or it does not in any way help to diagnose whether it is a relapse or it is a drug-resistant case, for which you have to see the slides, and you have to look for whether there are parasites and then the number of parasites and at which stage of development are they, right?
Yes, sir.
The direct slide test is more important than the antigen test.
Yes, sir.
Sushmita, should we declare or conclude?
I think we can conclude. Khub bhalo hoyeche. I think very excellent presentations from all three speakers. Very comprehensive and